come back and watch it. That work for y'all?
Yeah.
Yes.
Oh, I can unmute myself.
What?
I didn't know that neither. You can unmute yourself.
Okay, I'm going to unmute all. So if y'all have a question, be respectful. But if you are doing something such as eating cereal, you might want to put your own mute on.
Not too much now.
I like your background.
Okay, all right. So can y'all see my screen, the care of a client with neoplasms?
No.
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 Can't see anything.
You can't see anything?
I just see people.
Me too.
See people?
See, I can't see anything. I have a black screen. I don't know why.
Can you see my PowerPoint now?
Okay, I see it now.
Yes.
Can you see my PowerPoint?
Yes.
See your finger holder?
I can't see your
This thing say I'm driving.
All right, I'm gonna have to mute y'all again. Y'all be quiet. Okay. All right. So care of a client with neoplasms. Pay close attention to your ADLs, nutrition, and your toxicity, nausea, vomiting, your electrolytes that may get out of balance, and infection control. So what's some of our issues with infection control that we have to worry about with a patient of chemotherapy radiation?
Radiation therapy.
Toxicity.
Holton.
All right. So
What was the question?
what are some of the toxicity complications that we may see from radiation or from chemotherapy? All right, Lowlinger.
You need to mute everybody back because we can't hear you.
Oh my God.
Everybody.
Yeah,
Mute everybody.
Yeah, mute everybody.
Again.
Because they don't know how to exit.
Hey.
Oh Lord.
All right, everybody mute their microphone. Everybody mute your own microphone. Everybody. Getting better. McDaniels, I see your boom boom room. Okay, everybody muting their microphone. It's at the bottom of the screen.
I don't know how.
Just touch at the bottom of the screen. You'll see a little icons down there and a microphone. Touch that and it will mute it.
I see it now.
All right. JB, you raised your hand, unmute your microphone and tell me what are some of the toxicity effects of chemotherapy and radiation.
We're gonna worry about skin breakdown.
Skin breakdown and infection control. Exactly right. Okay, what else?
I don't know.
All right. Nausea, vomiting, your electrolytes getting out of balance, such as sodium. And if you have extreme diarrhea, then you'll worry about potassium getting out of whack, right? Right? Yes, do it. I am recording it now so we can view it later. Okay, let's get back on track. So infection control, we worry about washing our hands and making sure that if the patient has radiation therapy, that if they start to have skin breakdown, that they adhere to safety guidelines for prevention of infection. All right. delegations of duties. If we're talking about delegating duties to maybe a CNA or a UAP or even an LPN, for somebody with internal radiation, what are some of the things we're going to tell that employee?
I don't know how to raise my hand, but to keep
Me neither. I'm trying
to
to
keep the bed elevated.
Press the 3 little dots.
What
Okay.
dot?
All right, so for
Limit
internal
exposure.
radiation, you want to make sure that you use the acronym ALARA, as low as reasonably achievable. That means that you don't spend as much time at the bedside, that you're going to limit your visit to 10 minutes. So if somebody is spending too much time at the bedside, that might be something action we need to address. Okay, so everybody understands that? Delegation of duties. It's okay to empty the urinal into the commode. It's okay to bag the linens if they're not visibly soiled with blood in regular linen bags. But it's not okay to spend a lot of time visiting with the patient if they have an internal radiation, okay? All right, nutrition and medical diet therapy. Some of the things that we worry about with complications of chemotherapy and radiation. Dehydration is a big one, so making sure that if a patient comes in and they tell you that they've had nausea and vomiting and diarrhea for the last 3 days, but they're currently not vomiting, then my course of action is to get the IV going and get them feeling better, especially if they're symptomatic. So what would be a symptom that I would worry about if a patient came in reporting nausea, vomiting for 3 days?
Oh, I'm sorry.
Go ahead, Belgian.
Dehydration.
All right, dehydration. So my first course of action is going to start that IV, right?
Yes, ma'am. Giving fluids.
Okay. All right. And so remember that when a patient comes in, assess their symptoms, and the symptom that poses the biggest threat, that's the one we need to address first. So if they come in vomiting blood, then I'm going to put an NG tube down to help them not aspirate that blood, decompress the stomach. But if they come in and their blood pressure is low, then I'm going to have to address that first. Okay. Medical diet therapy. Patients with chemotherapy and radiation, they don't have much much taste. So what we'll do is tell them to season their food more, but not spicy, and to limit their fatty intake. Remember that. We don't want them to eat a whole lot of fried foods. Something like scrambled eggs is a real good choice because that's kind of bland. Popsicle always works. Because they're nausea and vomiting, then I may suggest deli meats that have extra salt in it, to kind of replace those nutritional deficits. All right, and so we talked about the complications of treatment. Chemotherapy. What happens if the chemotherapy escapes into the tissue and it eats the tissue around it? What's that called?
Extravasation.
Extravasation.
That's exactly right. And so that will happen, and that is a huge complication because that's your first line of defense is broken, your skin. So make sure that you always have a good IV when you're administering chemotherapy. A lot of people have ports, but not everybody. Not everybody wants a port. Then radiation, internal and external, we talked about the ALARA, but external radiation, you have dry desquamous and wet desquamous. What's the difference? Who's raising their hand?
One's dry, one's wet.
One's dry and one's wet, but the wet one has skin breakdown, right?
Yeah.
Okay, so that's the difference. All right. So care of a client with bone cancer, that's our third objective. So what are some of the most common types of bone cancer that we talked about? We talked about Ewing sarcoma, we talked about multiple myeloma, and we talked
Myeloma.
about metastatic bone cancer. But metastatic bone cancer is not a primary cancer. Y'all understand what I'm talking about when we say not a primary site. That means that it originated somewhere else, okay? So if you have somebody with metastatic bone cancer, I associate that with a high pain level that they will be reporting, because bone cancer is terribly painful, all right? So bone cancer, the most common types of primary bone cancer we'll see will be Ewing sarcoma and multiple myeloma. And we see a lot of multiple myelomas, okay? So multiple myeloma originated in the marrow of the bone. So what do you think our diagnostic test is going to be for this cancer?
Bone marrow biopsy.
Bone marrow biopsy, that's exactly right. And consequently, that's going to be our treatment too, will be a bone marrow transplant or a stem cell transplant. And those are very successful. So just remember that with bone cancer, multiple myeloma is our most common primary site. And
Miss Thompson,
huh?
I listened to your lecture, and I remember you saying like the bone type cancer that's the rarely primary is multiple myeloma.
All right.
I was listening to the recording, and I literally wrote that down from the recording.
What did I say now?
It said, like, you were talking about bone type cancers, and you said an example is multiple myeloma, and you was like, that is usually rarely a primary.
I hope I didn't say that that's rarely a primary site for myeloma. Hopefully I said that bone cancer is rarely a primary type cancer. It's usually a metastatic type cancer.
Gotcha.
If you do have bone cancer, the primary will probably be myeloma or Ewing sarcomas.
Okay, thank you. Sorry.
Does that sound better?
Yes, ma'am.
Okay, all right. So with bone cancers, we worry about safety, we worry about injury, we worry about falling. So, and a displacement of calcium in their system. So if calcium's supposed to be in the bone, but it gets pulled from the bone and it gets thrown into the blood system, then we may see elevated calcium levels, and that might be our only symptom that our patient may have. So pay close attention to lab work. If you have a patient that's diagnosed with multiple myeloma, always it's going to be pain and safety. Make sure that they are free from falls, they're not playing any contact sports, and that they adhere to safety guidelines such as wearing a helmet, seat belts, and things like that. Y'all understand about bone cancer, our main priority is keeping them safe and comfortable. Y'all got me?
Mm-hmm.
Okay.
Mrs. Thompson.
Yes, ma'am.
Trina Collins is trying to be added. Her phone is down and she's trying to get added on the iPad.
I see Katrina Collins right there. Is that not you?
She can't see it.
I can hear it, but I can't.
You can't see? I don't know. Can everybody else see?
Yeah.
Okay. Well, we're recording at Collins.
Tell her that she might have to turn on her video.
Turn on the video.
I can't see either.
You can't see what?
Anything. Like, it's still a black screen, and I have my...
It's a black screen. You don't see my PowerPoint. Does everybody else see my PowerPoint?
Yes. You probably
I
got
can see the PowerPoint. Yeah.
I can.
As long as you.
Okay.
All right.
Yeah.
Okay.
I get the PowerPoint.
You can see the PowerPoint?
I think it might just be...
Yeah, I can see it. I just can't hear
Like it's
Can't hear me?
slow. I don't have internet at my house, so I'm using like
Like I'm
my
yelling at y'all.
personal internet on my
Do y'all
phone.
feel like I'm yelling at you?
Hey.
Nah.
No?
I feel like you're talking over people.
Bridget's phone going in slow motion.
You feel like
Yeah,
I'm
I think
talking over
it's
people?
really the Wi-Fi connection.
Okay, it's the individual person. Okay,
Oh,
Yeah.
all right.
I don't know about
Remember
them, but
to-
I can hear them.
Remember
Right,
to
me
mute your
too.
I
phones,
hear good.
okay?
I just can't see anything.
All right. Everybody mute your phones, mute your computers so that we don't have all this back. And if you want to say something, then you can unmute, okay? All right, Hooker, I see your hand is raised. Do you want to say something?
That was from a long time ago, and you didn't call my name.
I didn't call your name.
So I don't.
Right,
No, I don't want to.
apologize. Let me lower your hand.
Anyway, so yes,
Okay. All right, so mute your microphone.
That's how I end up sending
Okay,
her a
GI
message, but I guess
system
she didn't.
function, GI system function, review the functions and interruptions at each phase. So if a person doesn't have any teeth, then their first phase of mastication is going to be interrupted because they can't chew and
I try. I don't know what I clicked off for a second. You went back to it.
please mute your
The
microphone.
volume went out. Huh?
All right, never mind. I'm getting out and I'm gonna mute everybody.
Your volume up.
Thank God.
Is your volume up? Your volume up. Oh, she got AirPods in her ear.
Yeah, I mute our microphone.
Ain't it? I'm weak.
All right, there we go. Now, I'm the only talker. Okay, so if you're reviewing the function and the interruptions at each phase, mastication, I would worry about dentation. I would worry about inflammation of the tongue, of the esophagus, anything that may hinder the propulsion that would get it down to the ingestion. All right, and so what would be some of your interruptions at ingestion? So stomatitis, esophagitis, remember your swish and swallow for that. That's the medication that has nystatin, lidocaine, and Maalox in it, and that will help coat the esophagus and push the food on down. So that would possibly be an interruption in the ingestion. Digestion, what would be an interruption there? That would be anything wrong with the stomach lining, such as ulcers, obstructions, slow motility. That would be an interruption there. And then what about absorption? You think about the small intestine and you think about the large intestine. And so some of the interruptions there possibly would be blockages and cobalamin that we get from the stomach. But all those things might interrupt the absorption. And then, of course, what would interrupt the elimination? Possibly constipation, paralytic ileus. A paralytic ileus is one of those common complications that occurs after surgery, and that's just when the gut slows down to a slow crawl or a no crawl at all. But a paralytic ileus is a common occurrence after surgery, and that possibly can cause constipation, and the patient may need extra treatment such as NG tubes or some other type of decompression of the system. All right? Okay, I'm gonna go on to the next one. All right, so diagnostic testing of the GI, make sure that you know the most reliable test for diagnosing a peptic ulcer disease. We all know that's endoscopy, and endoscopy is an upper GI, okay, upper GI. Other diagnostic tools that we use, fecal occult blood, that is where we take a specimen from the stool, the feces, and we check it for blood. So prior to checking it for blood, we want the patient to abstain from any type of anticoagulants prior to this test. We may also want them to stop their iron supplement about 3 days ahead of time. So make sure that you know the guidelines for getting a good fecal occult blood stool specimen, such as make sure they stop their Coumadin a couple of days ahead of time, and that they stop their iron and fresh fruits and vegetables, and no red popsicles. All right. Barium studies, when we have problems with patients with barium studies, it's usually from lack of a laxative after the study because they get terribly constipated. It sets up like concrete. So if a patient has a barium study, make sure that you add a laxative to your regimen, okay? And then we also could do ultrasounds and other lab work. Serum, that means we're going to get a blood specimen. Microbiology means that we're going to send it over to the lab that's going to check for bacteria. Chemistry, we're going to check the sodium, the potassium. We're going to check other electrolytes there. And then we may do a breath or urea test. We can do a urea test on fecal matter. And then pathology, we're checking it for any type of cancer. So those are the labs that you may see. But I want you to pay special attention to the fecal occult blood, okay? Give me a nod, everybody, that y'all understand that. Fecal occult, that's the guidelines for obtaining a specimen. And then barium studies too. All right? So our next objective was GI intubation, types of tubes. Our most common that we're going to see in the hospital setting is a Salem sump, and that's usually to help decompress a stomach that's gotten bloated for whatever reason. But what is the purposes of GI intubation? We use it for feeding. We use it to decompress the stomach. We use it sometimes after surgery to give the gut a rest so that acids don't get down into the colon and let them heal. But the purposes of intubation, make sure you know those. And then how to care for a GI tube, monitoring the output, how to do feedings, if you're going to check a residual before feedings, what degree that you're going to set a patient up for feedings, if you're going to flush with any water, and then complications that may arise from inadequate feedings, such as if the patient is aspirating, we may hear adventitious lung sounds. We may hear breath sounds that sound funny. We might even have signs and symptoms of fluid volume excess, all right? And then leakage around a new tube, it may cause damage to the skin area. So pay close attention to your skin area around your tube, okay? All right. And then GI conditions. All right. I'm gonna take a brief look at everybody. How's everybody doing? Give me a nod.
Fairly well.
Everybody doing well? Give me a nod. Y'all will understand anything?
now.
You can hear now? It was all those people. All right. Yeah, you're clapping your hands or you're raising your hand. I don't know, but good for you. All right. Okay. All right. So GI conditions and syndromes. Peptic ulcer disease, that was the big one that we really talked about a lot, peptic ulcer. So we've got three different types of peptic ulcers. We have a gastric ulcer that's higher up, a duodenal that's lower down, and then stress ulcers that can occur from patients who are bedridden or just maybe stressed out because they're in the hospital. So those are the three types of peptic ulcers that we talked about: gastric, duodenal, and stress, okay? And at our facility, everybody got Protonix for their prevention of a stress ulcer.
Mm-hmm.
Okay, some of the causes of peptic ulcers, we talked a lot about H. pylori, Helicobacter pylori, and that is because it's so common now and it's contagious. It's more contagious than this coronavirus because it's shared in the family and it's hard to get rid of. So when you're talking about H. pylori, I'm wondering about the treatment. So usually treatment is a combination therapy medicines. It's not just one pill. So we may use a combination of an antibiotic, a PPI, and depending on how irritated the stomach is, that we may use a cytoprotective if the stomach is really irritated. But usually it's going to be antibiotics, Biaxin, ampicillin, and a PPI. So remember, we'll talk more about medicines here in a minute, but a PPI, Nexium, Pantoprazole, Omazaprole, Prilosec, all of those zoles are a PPI, okay? And that's your combination therapy for GERD. All right, so we talked about GERD a lot during the simulation, and I wanted y'all to drive home your discharge instructions for your patient, because you need to make sure they know that they're going to be sleeping elevated from here on out. This is not something that they're going to get over. So it will be a lifestyle change. The diet, what they eat, when they eat, and what they can eat late at night. So I wouldn't recommend that they have milk or any products after 6 p.m. and they don't need to eat anything 2 hours before bedtime. Eliminate or decrease their caffeine, chocolate, peppermint, anything that may irritate their gastroesophageal reflux, okay? All right? So those are the important things I want you to know about reflux is the discharge instructions that you're gonna need to teach your patient, okay? All right, and so talking about inflammatory bowel disease, the two major ones that we talked about were Crohn's and ulcerative colitis. So remember, Crohn's, one of the telltale signs and symptoms that differentiates Crohn's from ulcerative colitis is the production of fistulas. And fistulas is any opening between two spaces. So that might be an opening between the colon and the bladder. It might be an opening between the colon and the vaginal wall. It might be an opening between the vag wall and the bladder. So when they come in and they're telling you that they've got a foul-smelling discharge from their bladder or from their vajayjay, then that might mean that they have a fistula and they may have Crohn's. All right, so that's telltale Crohn's. And then Crohn's, they also have weight loss, but it's over a long period of time. And then ulcerative colitis, they may have mucus in their stools. They may have rapid weight loss. But one of the most important symptoms that differentiates ulcerative colitis from Crohn's is the frequent diarrhea. They may have up to 20 a day, and it might be bloody. So if I hear that, I'm going to think about ulcerative colitis. So my treatments for both of these will be a biological medicine such as Remicade or Rituxan, and we think about those as the big dogs, all right? So when we're going to start out with that, we're going to call that the step-down approach. So when we come out with the big dog, then all we can do is go down from there. But if we start out something minimum, like with an anti-inflammatory, then that's a step-up approach. But for ulcerative colitis and Crohn's, probably we're going to do the step-down approach, where we're going to give them the big dog and try to hit it and get them better quicker. All right, irritable bowel syndrome, the telltales of that is diarrhea, constipation. So if they're in either one of those areas, then we're going to treat that symptom. If they've got diarrhea, we're going to give them anti-diarrhea medicine. If they've got constipation, we're going to give them a laxative. So we're going to treat whatever symptom they have. Yeah, my husband's fixing to walk through. Y'all hold on. He's fixing his hair. He doesn't think I know anything. All right, so irritable bowel, I call it the come and go. They're either stopped up or they're going too much. So that's irritable bowel. All right, that's your telltale for those. All right, now the difference between gastritis and gastroenteritis. What's the difference? Well, gastritis is just the irritation of the stomach. Gastroenteritis, otherwise known as the virus, and we're going to treat the symptoms accordingly. But gastritis, that inflammation of the stomach lining, we're going to give them a rest. So usually the stomach lining takes, or any of the GI lining takes about 3 days of light foods, such as clear liquids, to heal properly and let you go back to eating regularly. So 3 days will rest the GI system, all right? And that's gastritis. Okay. And then gastroenteritis, the virus, we're just going to treat the symptoms. Just like with this coronavirus, we're just going to treat the symptoms. If they got nausea, we're going to treat that. If they've got diarrhea, we're going to treat that. If they're dehydrated, we're going to give them fluids. And we're going to try to prevent them from getting really sick. That's the main objective of gastroenteritis, is try to prevent them from getting low sick. All right? And then nausea, vomiting, diarrhea. Your goal for those is to find out the cause. So if they've got nausea and vomiting from chemotherapy, then we may want to pre-medicate them with an antiemetic before they go to chemotherapy. If they have nausea, vomiting because of surgery, then we're going to know that ahead of time, hopefully, and we're going to run that off at the pass. And then diarrhea, what's the cause of it? Do they have a bacteria, a parasite? Or do they just have an irritated gut? So those are the things you need to consider with these GI conditions. All right? Everybody comfortable with me going on to the next? Give me a head shake.
Yes.
Yes. Okay. All right. All right. Medications. Let's talk about these medications. PPIs, proton pump inhibitors. That turns off the little pumps in the stomach that create acid. So to say that it's an anti-acid is not effective, but to say that it is an acid reducer by making sure that the pump doesn't make too much acid, that is accurate. But PPIs is a proton pump inhibitor. Come on, baby. Is a proton pump inhibitor. And come on, you can get up. Come on. Get up here.
Oh. Did I get that puppy? Oh, what is it?
Come on. Tell everybody hey. Tell everybody hey. Oh. Okay. So PPIs, those are proton pump inhibitors, and we're going to try to turn off the mechanism that makes all the acid so that we give the stomach time to heal. That's what a PPI does, okay? Now, an H2 blocker, a histamine 2 receptor blocker, is examples such as Zantac, Tagamet, and those are acid reducers, all right? That's their classification, is an acid reducer. And so Zantac, Retadine, Tagamet, Cetamine, let me think of, I think those are the two major ones that we use. Those are H2 blockers. And then antacids, that's that chalky stuff such as Malox and Toms and Rolaids. Those are antacids. And there's a time and a place for those, especially if your patient has too much acid such as GERD and their PPIs are not covering everything and they're suffering. So yes, they'll take their antacid. And then antibiotics, we talked about Bioxin and ampicillin. Those are the most common ones that we use for gut disorders. And then if we really get into some medicines, we'll talk about Flagyl. That helps with stomach irritation also. And then cytoprotective medicines such as Carafate. Those medicines will help protect the gut lining. And those are effective in preventing ulcers, all right? And then laxatives, of course, milk of magnesia, that's the old one. It's tried and true, it works, but people abuse laxatives, and when they abuse laxatives, their guts don't want to work anymore. And so we worry about patients who have laxative abuse. But if they take too much milk of magnesia, what do you expect is going to happen? Diarrhea, that's exactly right. They have overcorrected. Now, the timing of the medicine. Let's talk about timing of the medicine. I don't know if I said this in class. Surely I did, but I'm going to tell you now that the timing for a PPI is before your first meal of the day. Before your first meal of the day. So before breakfast, you're going to take your Nexium, all right? Before your first meal of the day. And then there is a break in between when you should take your antacids and other medicines. Let me see if I can find that information for you, because I know you're going to want to know this. Let's see. All right, Nexium, PPIs you take 30 minutes before breakfast.
PPI 30 minutes before breakfast.
Oh, you know what? I think I took that out. Okay, all right. So between your antacids and your PPIs, not your PPIs, your Zantacs and such, you can't take those together. Don't take your antacid and your Zantac together. Make sure that you have those separated out good, okay? Antacids and your Zantac, your H2 blockers cannot be taken together. They have to be separated. And usually we take our antacids after a meal, and we'll take our H2 blockers before the meal, okay? So everybody's clear on when we take our medicines. PPIs, 30 minutes before our first meal, and then antacids and H2 blockers, don't take them together. Make sure you separate them. Antacids usually after the meal, H2 blockers usually before the meal, okay? Everybody clear on that? Okay, and so the last objective that we talk about were the obstructive disorders, diverticulum, diverticulitis. We paid a lot of attention to this because we talked about the diets. And so the diet for maintenance of patients who have diverticulum, that means the little pouches, they're going to be on a high fiber, low residue diet. And the high fiber is to keep their colon cleaned out. We want them to have regular bowel movements, and we want their gut to work routinely so that they don't get constipated and create more pouches. That's a diverticulum diet, or a diverticular diet, all right? And then a diverticulitis diet is when you have inflammation of those little pouches and you need the colon to rest. Hush. You need the colon to rest and have time to heal. So we're going to be on a low fiber, low residue diet. And examples of residue or low residue items would be any type of meal that doesn't have a husk, any type of fruit that doesn't have seeds. That's low residue. All right, everybody understand what low residue is and low fiber? Okay, and then ostomies, the creation of an ileostomy. We may have large outputs from ileostomies, 1,500 to 2,000 on their first day post-op. But if they have more than that after that 24-hour time period, then we may experience or have a patient that goes into fluid volume deficit or dehydration. So we have to watch that really carefully with an ileostomy because they're going to have a large output. And then we also worry about the stoma. We worry about the stoma's health, the creation of that. And so the stoma needs to be cherry red. That's usually the color. Purple, dark, dusky, pale is not a good, healthy stoma. So make sure that your stoma is nice cherry red, and that usually indicates. And if you have that and your patient is fresh out of surgery, then we're just going to document those findings. We're not going to call the doctor to tell him something's normal. We're going to call the doctor when something's abnormal, correct? Okay. All right, so ostomy. So I'm trying to think about other ostomies that we talked about. Oh, a double barrel, that's a temporary ostomy. A terminal ileum That's a permanent ostomy. All right, y'all get the difference between the two? A terminal is permanent, and a double barrel ostomy is usually a temporary ostomy. All right, everybody understand that?
Took some medicine.
Okay, appendicitis. What's some of our telltale symptoms of appendicitis? Usually it's tenderness over the McBurney's point, but you gotta know where the McBurney's point is, and that's usually right over the appendix, which is on the lower right quadrant. I'm trying to point to it over here, lower right quadrant. So that is where the McBurney's point is. And what kind of pain you'll have there will be rebound tenderness. So your patient may present with an elevated temperature, nausea, vomiting, fever, and tenderness at that McBurney's point, okay? So that's appendicitis. If the appendix has not ruptured, then we're gonna take them to surgery, all right? We're gonna take them to surgery. And if it has ruptured, we're still gonna take them to surgery, but we need to make sure that we've got all our T's crossed and our I's dotted, and it becomes an urgent situation and not an emergent. Non-ruptured appendix is an emergent situation. All right, and peritonitis is what can happen if a patient has something that ruptures and leaks into the abdominal cavity, such as perforated diverticulum, such as a perforation in an ulcer, and that leaks and spills out into the abdominal area. And so that's a perforation, and that can cause peritonitis. Complications of surgery, paralytic ileus is one of those common ones. Volume changes, either deficit or too much. Make sure you assess your patient's lungs. Constipation after a gut surgery. We want them to be passing gas. That's a good sign that everything's moving in the right direction. So passing a flatus, there you go, flatus. That's one of those complications that we want to eliminate. And then small bowel obstructions, intraception, that's when the gut collapses on itself. And that is a complication after surgery. We don't see that too much, but usually that is a medical emergency, and we'll put an NG tube down and hopefully resolve that issue. Okay? I think that's it. It is. Okay. I'm going to stop sharing our screen now. And
I can finally see everyone now.
I'm going to unmute everybody.
Dad, put him outside.
All right, I've unmuted everybody. So make sure I'm going to post this, and y'all can watch this at your own convenience. But I want you to pay close attention to those hot topics that we went over today. Everybody feel good about that?
Yeah.
Yeah.
Yeah. Okay. Questions?
You know when we're gonna be able to take our test?
Yeah, how are they going to do the
tomorrow,
test?
What I know is tomorrow the college president is meeting with the deans of all of the schools, and they will come up with a plan for next week. Hopefully they'll let us at least come back next week so we can get started with our next lecture. And that's what we hope. And so that's what we're shooting for. So if you worry about, or if you believe in intercessionary prayer, that means everybody praying for the thing. Let's pray that everybody is safe and healthy, and that they let us come test on Monday.
Miss Thompson.
What? Got a question holder?
Oh, no, I'm serious. It's in Cleveland now.
Oh, it's in Cleveland. Oh, it's serious. It was serious last
There's
week.
two in
But, you know,
Bolivar.
we're
No,
going
but
to
now
do
it's
the
made it
same
me.
thing.
Exactly. It's not relevant until it's like close to you.
Yeah,
You
but
sure?
we're gonna take the same precautions that we do whenever we go in the hospital. We wash our hands, we make sure everybody else washes their hands. It's common sense, guys. But what's not common sense is the hysteria that's been associated with all of this. And so try to, as a budding health professional, decrease the hysteria, make everyone around you feel comfortable that we know what we're doing. And if everybody else will help us keep the hysteria down, maybe some of these politicians will back up a little bit and let the health professionals do their jobs.
Well, I hope they send us that $1,000. I'm fine with that hysteria.
What thousand?
I'm on my last roll of toilet paper, so.
All right, guys, y'all listening to me? We've got to have a grade associated with this. So I'm going to put a little quiz up, and everybody should make 100 on it because we just went over everything in this little PowerPoint. I'm going to let y'all review the PowerPoint at your leisure, and then tomorrow you will take this little quiz. It'll be open all day, and I say all day. I'm going to close it at 5 so I can record the grades. And then once you do that quiz, then that has clocked you in for the weekend. You don't have to make this week up. Everybody cool with that?
Yes.
This concept.
Huh? Alan? All right, hold on just a second. If you have a personal question regarding your person, call me or send me an email. Let's not use our class time to discuss personal things, okay?
No, I just want to ask you guys. I want to ask you guys.
Oh, y'all stop doing it because y'all all in the same car.
Cause they
Okay.
all in the same car, so that's why it's echoing off them.
What was the question?
Who y'all need to mute?
Will I be able to take the test?
Will you be able to take the test?
Yes.
All right, that was just asked by somebody that when you're going to get to take a test. I have no idea.
I need to pay attention.
Tell them, partner.
Everybody got something to say.
What are we gonna do if they close the school down for the rest of the semester?
Hey, we're going to pick up and go on with it. I'm not quitting. Are y'all quitting?
No, I don't have something else to
Several of the nursing programs, though, that will be taking their test on Proctor.
Hey, do what we got to do. It might be that we have 10 people come to school at one time because we can't have more than 10 people together. We'll do what we got to do. All right? Y'all let us worry about that. Y'all don't worry about that. Y'all need to study for this test and make it good. Okay?
Something. So we just need to study for the test, right? Like we don't need to be trying to work ahead.
No.
Okay.
Don't work ahead.
Okay, good.
Ms. Miller's going to start her lecture just as soon as we get Unit 3 taken care of.
Okay.
I don't like this.
Me either.
It's not really up to us to like it or dislike it. It's up to us to deal with it. And so we're dealing with it the best way we can. And you see me, I'm going crazy at this house by myself. So I might just log in and talk to y'all once a day just so I can get my fix, okay?
You should by yourself. I got to work with 3 kids.
Well, send one over here.
I have a question.
All right. Ask your question.
It's class material. Because I was getting confused with the small intestine or the small bowel obstruction when you said something about acidosis or alkalosis.
Okay, so if you've got an obstruction up higher in the system, up higher, and you put an NG tube in, you're going to be sucking out all that acid. So you may have an alkalosis type situation. But if your blockage is lower, then you might have an acidotic because it'll build up in the system and you're not able to eliminate it. So a blockage up higher, you lose too much acid, so you'll have an alkalosis type situation. All right, y'all understand that?
Is that star asterisk asterisk?
So, well, let me just specify this since it's a star.
Star,
Dang.
asterisk.
Okay,
Circle.
okay.
Not the circle.
All right.
I hate here.
Here, Stella.
I'm looking to make sure I told y'all everything. Complications of radiation in this area, we worry about the ABCs. Airway, breathing, and circulation. So if I'm radiating in this area and my throat, I worry that I may not be able to breathe or swallow, okay, in this area. Y'all see my area? Okay.
Look at there.
Know your electrolyte levels. Know your levels. Your sodium levels, your calcium levels, your potassium. If you have a choice that says wash your hands, please choose it. Okay. Any other questions? Any other questions?
I don't think so.
You can give us more information.
I just gave you. I love you all. Terribly miss you all badly. And hopefully I'll see you on Monday.
Yes, ma'am.
Oh, how many questions gonna be on this quiz?
Amy Mountain's on the other one. Steve.
The quiz.
Oh, the quiz?
They so funny.
You listen to me. Okay.
Yes, ma'am.
10.
You say 15 or 10?
Somebody's at my door. All right, guys. Love y'all.
All right, Miss Buster.
They too.
Bye.
Yeah.
How you hang up?